So I want to start today's program. It is our pleasure to host the recipients of the 2023 ATI Undergraduate Summer Student Award today. The annual ATI Summer Studentships allow undergraduate students the opportunity to undertake a summer research project in the laboratory of an ATI member. In addition, the Jamie Fleming Summer Studentship Award was made by a generous donation from Nancy Fleming in memory of her husband, Jamie, and is awarded to an undergraduate student registered full-time at the University of Alberta for a research project relevant to lung transplantation. I want to, before we go into each of the award presentations, I want to ask everyone to hold your questions until the end, until all speakers have provided their presentation. Justin, are you ready?
Yes.
Okay. So Justin is the first speaker, and Justin is supervised by Dr. Karen Doucette. I'm going to give a very quick and short bio before I'll let you take it away. Justin is a second-year medical student at the U of A, and he grew up in Edmonton and also did his undergrad degree here with a BSc in Biological Sciences. Previously, Justin has worked with the Mental Health Commission of Canada, as well as AHS as a contract tracer in the era of COVID-19. Justin believes that it's been an amazing opportunity to work with ATI, Dr. Doucette, and the HOPE team. And the past summer has furthered his interest in both transplant and infectious disease research. And he would love to continue to explore this area within medicine.
So again, my name is Justin. I'm a second-year medical student here at the U of A. And today my presentation is going to be on my summer project, which was characterizing the infection risk profile of organ donors in our HOPE organ donor program here in Northern Alberta with AHS. Okay, so just a brief introduction. Current Canadian organ donation guidelines include what's called these medical social history questionnaires. Essentially, when a recently deceased donor is in the process of having their organs evaluated for transplantation, their next of kin or their loved ones will answer these questionnaires to evaluate certain risk factors that they may have engaged in, like lifestyle activities and whatnot, so that we can get a better assessment of what risk those organs have in terms of transplant. So within these questionnaires, donors with this increased risk donor designation can only donate through a process of exceptional distribution. This can get a little bit confusing, but I'll get into it in just a little bit, just to help better explain and clarify what it is. So a brief introduction into what increased risk donors are. Like the sum of it is that these are individuals that have engaged in behaviors that are associated with a higher risk of contracting HIV, HBV, and HCV. So high-risk activities include predominantly injection of drugs, being incarcerated, and engaging in high-risk sexual behaviors. So let's talk about exceptional distribution of IRDs and what this means. So I won't read this because this is just some criteria here, but you can see it for your own interest. IRD organs can be offered under this umbrella term of exceptional distribution if they meet this criteria. But it's important to note that here, for individuals that are labeled as IRD or having their organs labeled as IRD, follow-up testing of recipients are required. So this would include HIV and HCV NATs at 1 to 3 months, and we do Hep B screening as well at 1, 3, and 12 months. So to just clarify how this designation really works, think of exceptional distribution as an umbrella term in which IRD is one of the branches within it. So when we talk about increased risk donors, all donors classified as an IRD will be an exceptional distribution donor as well. However, not all EDs are IRDs, if that makes sense. So that's just how the classification works. I'm happy to answer any more questions about that later on as well. Okay, so let's talk about the impact on organ transplantation now. This is where stigmatization and labeling really comes into play when we talk about medicine and transplantation. Because the reality is some patients are unwilling to accept IRD organ offers if they're on the wait list. Because in the process of informed consent of getting a transplantation, obviously donors are notified recipients are notified that their organ had come from an increased risk donor. So with that designation, again, this comes with a lot of kind of perceived legal risk. There's perceived medical risk as well with that. And unfortunately, a study in 2010 showed that IRD organs were actually discarded at 1.5 times the rate of comparable non-IRDs. But this is despite having excellent outcomes, which is what I'd like to point at when we take a look at these figures just to the side of the slide. So you can ignore this line here. I just want the audience to pay attention to these two top lines here, and we're talking about patient survival and graft survival in both of these graphs. So the dotted line is non-IRD donor survival, and the solid line up here is increased risk patient survival, patients that receive like an increased risk organ. And you can see that the outcomes are virtually identical. So really, again, we put this label because we've indicated that, you know, these organs do maybe confer an increased risk of having certain diseases and whatnot. But at the end of the day, it's the cost benefit of an individual already being on a wait list. And we know that with transplants, supply and demand is so big and resource allocation is, you know, such a big bottleneck. And whether it's better to just get that organ or to continue to wait for another organ that is not like labeled as increased risk. So to further demonstrate this, like turn down for what? So why are patients turning this down even for when we know what the outcomes would be if they actually just took the organ in the first place? So patient outcomes that are associated with declining increased infectious risk kidneys. So again, this is data that is dealing with kidneys in particular in kidney transplantation. And you can see from the individuals that declined their initial offer of having an increased risk organ that a good 15-16% of them were still on the wait list. 19.5% were removed from the wait list because cumulative risk increases the longer that an individual is on a wait list. So for an individual to get removed from a wait list, that could have been because they suffered like a medical episode, like whether it was an MI or something else, in their waiting period while they were waiting for another organ that was like not increased risk organ. And you can see that up to 20% of individuals actually died, within 5 years since they declined that original IRD kidney. This further emphasizes that point of, like the cost benefit of just accepting that initial increased risk organ. KDPI is a viability marker for kidney transplants. And typically the lower KDPI that you have, the more viable or the more healthy your recipient organ is going to be. So you can see that with IRDs that previously declined, the organs that they ended up accepting later, if they were lucky enough to even get non-IRD organs, were actually of lower quality as the KDPI increased over time. So yeah, there we go. And one more figure to kind of just hammer home this point, we can look at cumulative mortality over 5 years after the decision was made. For individuals that declined that initial IRD kidney offer, their mortality was higher than individuals that accepted that original offer. So this leads us to our project and why are we here? We hypothesize that the proportion of IRD donors as part of the total exceptional distribution donor pool is increasing over time. And for us, this is predominantly explained by an increase in drug use and overdose as a cause of death, particularly in the past few years. So just a bit of background about this to talk about changing donor demographics, and in particular in Canada and North America. As a lot of us know that there has been an increasing and quite important overdose crisis and an opioid epidemic, in particularly in British Columbia and Alberta. And you can see that these rates really skyrocket post 2015. So, just using this as background information, we believe that this increase in overdose deaths is also being reflected in our donor pool as well. So our objectives in this project over the summer was to review donors in the HOPE program from 2013 to 2022. The caveat here with this presentation is that we only have data here up until mid-2017. We're still trying to finish the remainder of the data and have the full data set available soon. And two of our main objectives here were to characterize the donor infection risk profile and using Health Canada standards, classify the proportion of donors that were classified as IRD, and to describe the donor risk factors and serology results of these individuals during this period. So methods, this was a single center retrospective cohort study. We did collect our data mostly through donor chart review. And as I mentioned prior, IRD classification was applied according to the Health Canada CSA standards. Okay, so taking a look at our results, I'll point out some important things here. So these are our donor demographics that we were able to, let's just take a preliminary analysis of from what we saw over the summer. So the donor sex assigned at birth, 2/3 of our donors ended up being male. Donor age was about 46 for the median age. Donor country of birth, most people were born in Canada, although we had a good proportion that were also born outside of Canada. And the main point that I'd like to make here is a focus on donor serology. So the first 2 points here have to do with hepatitis C virus antibody serology and nucleic acid testing. So you can see that the positivity rate for our donor population, so until mid-2017, we have about 644 individuals that we were able to analyze charts for. And the overall positivity rate for HCV was about anywhere from 1.4 to 2%, depending on which sort of testing that you were using as your metric. But the last two results here are in particular interesting for what we want to continue to do with our investigations, which is to talk about the IRD HCV positivity rates and the non-IRD HCV positivity rate. So this figure here, IRD HCV antibody positive, this was out of the total pool of just IRDs. So there were approximately 135 individuals that were identified as increased risk during our analysis in this period of time, and about 7.41% of them came back HCV antibody positive. And for the non-IRD positive pool, so 644 minus 135, only 0.59% of them came back HCV antibody positive. So, like intuitively, as you can tell, obviously an individual that has been labeled as increased risk would then, in practicality, have an increased risk of actually having HCV, which we've shown here. But pragmatically, when you talk about transplant, that's still over 92% of individuals that were part of this IRD donor pool that were HCV negative and that had organs that were perfectly fine to transplant. And even within the population that were characterized as HCV antibody positive, recent advancements in medicine and antivirals have made HCV a largely curable and treatable condition. So really, as we talk about again, I'll allude to it once more, the cost benefit of getting an organ that may or may not have a low chance of being HCV antibody positive versus not being able to get an organ or having an organ that's of lower viability is really at stake here. Okay, so figure 2, the proportions of RDs and EDs over time. As you can see, it really skyrockets post 2015, but as the total number of EDs have increased over time, so have RDs as well. When we talk about donor demographics and what their cause of death was by, this is just consistent with the background data that I presented earlier. And I do just want to make an emphasis of overall deaths caused by overdose. And you can see that, it trends upwards, right? Especially post 2015, as I mentioned again, that seems to be that inflection point corresponding with our opioid epidemic. 2015, 2016, 2017, we're making big jumps in deaths due to overdose. And that also corresponds to these medical social history questionnaires as well, indicating that the proportion of our IRDs who injected drugs over time also skyrocketed post 2015. And lastly, this figure here is just to show the proportion of IRDs classified as EDs over time. And again, a reminder, ED is overall umbrella term, IRD fits within that. You can see as well post 2015 that the number of IRDs that make up that ED designation actually becomes over 50%. So the majority of EDs were IRDs post 2016 and going into 2017. So our conclusions from this data so far, again, the proportion of IRD donors, at least in the HOPE program, is increasing over time. Of the donors classified as IRD, the proportion due to injection drug use is also increasing over time. And lastly, as I showed in the last slide, while the majority of ED applied isn't due to IRD classification in this time range, the latter 2 years, particularly in 2016 and heading into 2017, does indicate our trend of increasing IRD designation that does warrant further investigation. So our next steps are further investigation. So again, we're going to finish up our data set, which takes us to the end of 2022. We're in the process of doing that, so that should be finalized sometime soon in the next upcoming weeks. We want to further take a look at different serologies. So I know a big point of emphasis within this talk was hepatitis C in particular, but we also want to take a look at HIV and in particular syphilis as well, because we know that in Alberta, especially, syphilis rates are really increasing over time. So that's really it for us. And our acknowledgements, again, thanks to Alberta Innovates and of course ATI for having us, funding this project and for letting me speak today. So again, whether it's right now or later on, I'm happy to take any questions. Thank you so much.
Our next speaker is Ivan Ma, supervised by Dr. Jason Acker. And again, a short bio. Ivan is currently a master's student in the Department of Surgery and recently completed his undergraduate degree here at U of A in biological sciences with a minor in chemistry. Ivan was born here in Edmonton, but lived abroad for a couple years before coming back here for high school. He's also currently works part-time as a lifeguard and enjoys activities like swimming, hiking, bouldering, and working out. So Ivan's studentship was sponsored by Jamie Fleming Summer Studentship Award. Ivan, are you ready to present?
All right, hi everyone, my name is Ivan, and I was giving a short presentation on my summer research project, which was on ice recrystallization inhibitors are non-toxic in a rat lung perfusion model. Just to start off and give a little bit of introduction into this project. So one of the main issues we're facing with lung transplants, or really any organ transplant, is that there is a limited supply and a much greater demand. And part of that is because of poor allocation resources. And one of the contributing factors to that is also that we have a very limited storage time. And so current practice involves storing organs on ice from anywhere between 4 to 6 hours. And so if you do a Google search, a flight out to Toronto is about 4 hours, to Montreal it's about 6 hours. So if you could imagine we have a donor come up here in Edmonton and we have the perfect match or recipient out in Toronto or Montreal, we have very little room for error and everything would have to run smoothly in order for that recipient to receive that organ. And so that's why cryopreservation is an area of interest right now, as it offers the opportunity to extend that preservation time. So if you could imagine, if we could extend preservation time even by a couple hours, we could look at transporting organs nationally. Even longer than that, now we could match recipients and transport organs globally. And even further down the line, if we could find ways to store organs indefinitely, we could start looking to build organ banks where we could store organs for much longer periods of time and match them across the world. Now, cryopreservation does have some issues. One of them being that there is this phenomenon called ice recrystallization. And essentially what this means is that when you have a frozen material, you have ice grains of different shapes and sizes. And what happens when that material thaws is that the large ice grains will actually grow and get bigger and bigger at the expense of the smaller ones. And it's this growth of these ice crystals that causes enough damage to the organ such that they're no longer safe for transplantation. And so that's why we're investigating these molecules called ice recrystallization inhibitors, which are essentially these small carbohydrate-based molecules that are capable of inhibiting or controlling that ice growth during that sort of freeze-thaw cycle. So for our project, we hypothesized that the IRIs are safe for the rat lungs and that they can control the growth of ice during that freeze-thaw cycle. And so we had two main objectives. The first one was to assess if there were any toxic effects from the use of the IRI. And then secondly, to highlight the ability of the IRIs to actually control the ice growth in the lung tissue. So here's a general overview of the experiment. So we would start off with doing surgery to procure the organ. We would then perfuse the lung for 4 hours. And that really encompasses sort of the first objective, which is looking at the physiological parameters and to determine if there are any toxic effects. From there, we have the second half of our experiment, which looks at taking core biopsies from the lung tissue after the perfusion. We would snap freeze them. And then so there are two treatment groups. The first one, transient warming, which takes that core and it goes through sort of a freeze-thaw cycle where heat goes cool down and then it warms up so to induce that ice growth. And then we just have a frozen group. And so really this second half of the experiment looks at objective 2, looking at ways where we could actually look at how well we were able to control the ice growth. And so those core biopsies go through this freeze substitution protocol. And essentially what that does is it fixes the ice so that we can later detect and visualize it when we do histology. So looking at the perfusion apparatus here, just a schematic of it. The perfusion apparatus allows us to ventilate and circulate fluids through the lungs. So here looking at A, we have our reservoir where we have our perfusate. And the perfusate is where we can dissolve the IRI and where it goes. It gets drawn up by a pump into our deoxygenator here, which is connected to a gas canister and a pressure transducer, where it then goes to a gas bubble trap, and then it goes to the lungs, where we have it cannulated through the pulmonary artery, and it then drips out through the open left atrium, and that gets recirculated back into reservoir. So you may ask why we use a perfusion apparatus, and there are a couple reasons. The first one being that perfusion apparatuses have been shown to actually improve lung function over time, as well as actually extend preservation time a bit. And secondly, the perfusion apparatus allows us to actually monitor the lungs in real time and see how they're functioning over a set amount of time. If there are any toxic effects or if the lungs are declining in function, we will be able to see that. And then thirdly, with the perfusion apparatus, this is a possible method in which we could actually deliver the IRI by having it dissolved in the perfusate and have it circulated to the lungs this way. So I just have a little video here. And you can just see here, this is sort of the lung. This is the left lobe and the right lobe. And in the background, you can see my hand. That's where we sort of are able to take our perfusate samples, and then we run a blood gas sample on it, where we can then look at oxygenation, pH, and all those other physiological parameters. And then on the right over here, I just have an image here of the lungs at T0, so at the very start of the perfusion. And just an hour later, you can see that the lungs open up and sort of are recruited and look a lot better. So looking at our results here, we have our functional measurements. So the first one being edema. The edema score we obtained from after the perfusion, we would take the right upper lobe, we would weigh the weight of that wet, and then we would let it sit for 48 hours and weigh it again to get that dry weight, which then gives us this edema score. And as you can see, between the control and IRI group, there's really no significant difference. And then our second measure of function was the oxygenation index. And again, you can see that there's really no difference between the control and IRI group. And sort of the physiological parameters that we were able to monitor, we have the vascular resistance as well as the pulmonary artery pressure. And for the two groups, control and IRI, there was really no difference. You see here with static compliance, that within the groups, so like within a control group, it was different at T0 compared to T4, and same thing with the IRI group. And really what that means is that the compliance actually improved over time. And what compliance is a measure of the elasticity of the lungs. And it's a calculation based off of the per unit change in volume over the per unit increase in pressure. And so earlier I showed you an image of the lungs sort of getting recruited from T0 to T1, how they open up. And that's really what this shows, is that as the lungs open up, they can take in more volume, and that increases or improves compliance. So looking at sort of the second half of the experiment now, where we looked at the ice grain analysis to see if the IRIs were able to control ice growth. So from those core biopsies that we took earlier, we snap froze them, we took them through the whole freeze substitution protocol, and we took slices of that to get these H&E slides. And you can see here sort of zoomed in, we have the bronchial, we have the alveolar spaces, as well as the vessel here. And in these colored regions around the bronchial and vessel, you can see that this is what we've identified as ice. So looking into the analysis, we measured the area of the ice grains around the perivascular region as well as the peribronchial region. And what we were able to find was that there was actually no difference between the IRI and control group. No significant difference between the two, but we did see that when you compared perivascular to peribronchial, there was a difference between those two regions. And so we had two main conclusions. The first conclusion being that the ice recrystallization inhibitor was not toxic to the rat lungs, as there was no difference in physiological function. And secondly, that for the peribronchial and perivascular regions, there was no significant difference in ice grain between the control and IRI group. And that sort of leads into what we're trying to work on right now, is a future direction is we're trying to quantify the ice in these alveolar spaces that we weren't able to see. As you saw earlier, it was just white space. So if we were able to figure out a way to maybe quantify the ice in those regions, that might be able to actually highlight the effects of the IRI. And just some acknowledgements. I just want to thank the Dr. Nagendran and Acker Lab for all their support and guidance. And I also want to thank Jamie and Nancy Fleming for providing the Summer Studentship Award and giving me the opportunity to pursue this research. Thank you.
Going to move on to our final speaker and student awardee. And this is Kristi Papamihali. And this Kristi was supervised by Dr. Constantine Karvellas. A short bio. So Kristi is a third-year medical student at U of A. She completed her Bachelor's of Science degree at U of T, followed by a Master's of Public Health at Simon Fraser University in BC. Following the completion of her master's degree and prior to starting medical school, Kristi worked as an epidemiologist at the BC Center for Disease Control for 3 years. She was funded by an Alberta Transplant Institute studentship this past summer to collect data on liver transplants in Edmonton.
Great, thank you so much. Thanks for having me today. So I'm here to present about our project from the summer on characterization and postoperative outcomes of liver transplantation, which is going to be just a preliminary review of liver transplants that happened in Edmonton in 2022. And I'm supervised by Dr. Constantine Karvellas here at U of A. So just as some background, which of course is no news to the group here, but liver transplantation is an increasingly frequent procedure which improves the survival of patients with end-stage liver disease. And while it has survival from liver transplantation has improved over time, we're also seeing more post-operative complications. And this is mostly due to kind of the objective prioritization of the sickest patients to receive transplant, as well as improvements in care, which have led to better survival. But again, with prioritizing the sickest patients for transplant, you're obviously also going to see more complications. And of course, we care about reducing complications because they increase mortality, they increase readmissions and cost of care, and of course, decrease the quality of life of patients. So in keeping with that, we're always looking for ways to decrease the risk of complications. And one study that's doing this is the Ellipto study, which is being led by Dr. Francois Carrier out of the University of Montreal. So Ellipto stands for Enhancing Liver Insufficiency and Postoperative Transplantation Outcomes. And this is a 3-part study, and we're currently at phase 2. So in the first phase of the study, their goal was to kind of do a survey of clinical practice of anesthesiologists kind of across the country to see how they manage hemodynamics and fluid resuscitation during a liver transplant. They found that there was quite some variability in the management, and so the next step of their study was to see how patients are doing across different centers in Canada. And so the stage 2 is intraoperative hemodynamic management and how it impacts postoperative outcomes in liver transplant patients. And as I said, it's a multi-center prospective cohort study. And so this is where U of A comes in, because our liver transplant program here at the U of A was enrolled as one of the sites in this multi-center study. And since this was kind of my job as well, so this summer I collected data, quite extensive data collection on liver transplant recipients in Edmonton in 2022 to feed into this study. And we have now completed data collection, but since we now have our local data set, we also just wanted to kind of take a look at what we saw in terms of liver transplants in Edmonton. And so that's kind of the objective of the presentation today, is as a part of our initial survey of the liver transplant program data collected for the Ellipto 2 study, we wanted to describe some of the characteristics and outcomes of patients that underwent liver transplantation in 22 in Edmonton. So in terms of the methods, so for data collection, we did a retrospective chart review, and inclusion criteria were all adults that underwent liver transplantation in Edmonton between January and December 2022. We excluded, recipients that had repeat liver transplantation within the same study period were only counted at the first event, so they were excluded from further, they were not counted again in further events. And then the follow-up period for complications and mortality was assessed up to 6 months post-operatively. In terms of our study variables, they were quite extensive and they were broken into three areas of data collection. So preoperative factors, intraoperative management, and postoperative complications. So in terms of preoperative factors, we looked at demographics, etiology of liver disease, the indication for transplant, any comorbidities that they had, as well as donor info, including cause of death, demographics, and also as well as their preoperative status. So use of if they were admitted to ICU prior to the transplant or not. In terms of intraoperative management, which I'm not really going to cover in today's presentation, but we looked at many different factors that cover intraoperative management, but that included duration, the management of anesthesia, use of labile blood products or vasopressors, as well as the key surgical characteristics. And then in postoperative complications, we looked at graft dysfunction up to 6 months post-op. We also assessed development of other complications within the index hospitalization. So looking at acute kidney injury, infection, pulmonary complications, or thromboembolic complications, which were assessed up to discharge. We also looked at surgical reintervention after the liver transplant, the length and course of their post-op ICU stay, and then we also assessed 6-month mortality. So in terms of our results thus far, so in terms of demographics and liver disease, overall we had 94 patients that had a liver transplant and admitted in 2022. The recipients were primarily male, with about 68.1% being male, and they had a median age of 54. But more than half of the patients were in the 50 to 69-year-old range. In terms of the indication for transplant, the majority of indications were due to chronic end-stage liver disease and hepatocellular carcinoma, which accounted for about 75% of the entire group. There were about 10% were due to acute liver failure, and 5% were being retransplanted. In terms of the etiology of liver disease, the majority of cases were due to alcoholic cirrhosis or viral hepatitis. Non-alcoholic steatohepatitis also made up a good proportion at about 20%. And then fewer cases with autoimmune cirrhosis or hepatitis, primary sclerosing cholangitis or primary biliary cholangitis, or due to prescription medication, which actually didn't include acetaminophen toxicity. In terms of the comorbidities and pre-op status, so majority of patients had some sort of comorbidity. As you can see, only 6% had nothing else going on. The majority of comorbidities were related to hypertension with about 40% and diabetes with about a quarter of the patients, and less so with other categories of disease. Of the 94 liver transplant recipients, about 10% were admitted to ICU preoperatively. So we're in a pretty critical state prior to the transplant. And 16% required preoperative organ support in the form of either vasopressors, renal replacement therapy, or respiratory support, which could have been invasive or non-invasive. When we looked at postoperative complications, so overall, 63% of transplant recipients had any kind of postoperative complication. Now, disclaimer here is that that could have been a complication of varying degrees of severity. So we just counted everything here, but some of these things might not be very severe. So when we looked at graft complications, it was about 30% of recipients that experienced graft complications up to 6 months post-op. Primary graft non-function was less common at about 3%. Hepatic artery thrombosis at about 4%, and biliary complications were what we saw most commonly, which is about a quarter of all recipients experienced biliary complications in the 6 months post-operatively. 3% also required retransplantation within that 6-month period. In terms of hospital or complications that developed post-operatively while in hospital, 12% of patients required renal replacement post-op. Another disclaimer there is that a fraction of those patients also required renal replacement therapy prior to their transplant or during the transplant intraoperatively. So not all of those, not all of the patients that were placed on renal replacement post-op were new renal replacement. About 34% developed pulmonary complications and about 30% developed infections, and only 2% developed thromboembolic complications. About 22% of the patients required surgical reintervention post-op, and that was sometimes if the patient the surgery had not been completed after the liver transplant, required closing, and other times it was related to an exploratory laparotomy to kind of troubleshoot complications that were arising. In terms of their ICU course and mortality, so of the 94 liver transplant recipients, 9.6% were readmitted to ICU after their initial post-operative discharge. So everybody was admitted to ICU post-op, but 9.6% of patients had to go back to ICU after being discharged from ICU. The length of post-op ICU stay for about 70% of patients, that was less than a week. But 15% of patients were in ICU between 1 to 2 weeks, and 6% 2 to 4 weeks, and about 6% also were in ICU for more than 1 month. At the end of the index hospital visit, so the transplant visit, 90.4% of patients were discharged home. 2% were transferred to an acute care facility, and 7.4% died while they were in hospital. And when we looked at 6 months post-operatively, about 10.6% of patients had died at that point. So in conclusion, like I said, this is kind of like a preliminary survey of our data that we collected locally for the Ellipto study, but it provides an overview of liver transplantation that happened in 2022 in Edmonton, and highlighting here a relatively high prevalence of postoperative complications. But like I said, these are of varying severity. So for things like infections, for example, they might have just been treated with antibiotics for a few days and things resolved, or it might have been something that led to something like sepsis and further complications. So that's something that we will be teasing out in the next stages of our study. And we also saw a 6-month mortality rate of 10.6%. Typically in the literature, mortality for liver transplant at 1 year is about 10%. So this is a little bit higher than we'd hope to see. So in terms of the future directions, first of all, the Ellipto 2 multi-center study that we submitted our data for is currently, they're currently doing their analyses. So that's something to look out for, where they're going to assess kind of the impacts of the hemodynamic management during surgery on the postoperative outcomes currently in progress. And one of the things they're going to try to do as well is kind of compare outcomes across the multiple centers across Canada, as well as I think 1 or 2 centers in France that are also part of this trial. And it will inform the future randomized clinical trial, which is Ellipto 3, to see if more restrictive fluid management during surgery is going to actually lead to better outcomes for transplant recipients, which is the hypothesis right now. As well, with our local data, we're hoping to do some further ancillary studies to identify additional preoperative or perioperative factors that can be optimized to reduce complications and improve outcomes for liver transplant recipients. So that is my presentation. Thank you very much to Alberta Transplant Institute for funding me and for the ability to do this project. And then thank you to the Ellipto team, of course. That's everything.
So I'm gonna congratulate all 3 speakers again for obtaining the prestigious Summer Studentship Award, and kudos to your research, and we look forward to the final forms of your research and publication form. So I'm gonna open the floor up to the audience for Q&A, and we should have time for 1 question per speaker. So if you can type your question in the chat box. I'm gonna do my best to read it out.
Can you hear me, Tony?
Yeah, I can hear you.
My question actually is for Kristi. I might have missed it with regards to the donor types. Did you tell us living donor versus deceased donor, and then within deceased donor, which type of deceased donor, whether they were DCD or NDD donors, just since we know that there's potentially a confounder there or certain contributing. You probably need to come up to that.
Sorry, I think you should go a little back because the camera can show you the workout.
Yeah, so I didn't mention that, but we definitely have collected that data. And if I remember correctly, I think we had about 60% or so, 60 to 70% that were D&D donors and about 30-something% that were DCD donors. But yeah, we've definitely collected all the information on donors, including the cause of death, the type of donor, age, and also things like reperfusion time and other surgical characteristics to kind of tease out if it was the organ prior to transplant that could have contributed to some of the outcomes. Yeah, I didn't present that information today, but we definitely have collected it and it's part of the variables. Yeah, no problem.
So with that, thank you so much for attending today's seminar and celebrating the trainees' success.